Hi everyone. I hope you all are doing very well. I hope you all are staying dry, staying warm, and staying healthy. We are now in our 10th week of the semester. We're in our third week of this online format. So I hope that this transition hasn't been too rough on you all. And if there's anything I can do to support you, please do let me know. For next week, we are going to try what's called a synchronous class. So that means we're going to have meet in vivo via WebEx. I'll send out all the details for you all, and that way we can have a little bit of time just to check in. And we will meet at our regularly scheduled time. Since I know that that is a time that probably works best for most of you. If not, let it be a thought that you can put into our discussion board post. So I'll open up the discussion board post and y'all can indicate what time would work best for you, and we can all meet and then we can have just a brief check-in. Any questions you might have in terms of that no credit grade and assignments, etc., we can just try to hash it all out. But with that, today with our lesson, we're going to be going over low incidence disabilities. And so this time around, you don't really have to take notes or pose any questions on our discussion board forum, though I do want you to keep in mind how this is going so far in terms of this online format, just touching base with you in that sense, just trying to see what I can do to tweak things, change things around, whatever it is, so that you're getting this content that you need and you're still making progress. Nothing is going to hinder your progress. And the other thing is I'll also post it in the discussion board form as a discussion, whether or not we should continue on with this midterm. So that's something to think about as well. If I'm open to hearing what y'all have to say and share. So do keep that in mind as you were going through this session tonight. So with no further ado, let's go ahead and dive right on in. All right, low incidence disabilities. Here we go. Alrighties, guys. So first off, what in the world is low incidence? Well, right in that word, low incidence. So that means the rate in which this disability is occurring, it's very low. Specifically, how low? It must be, look at this, less than 1%. Alrighties, folks? That's all it means. So your low incidence disabilities refers to a category that in your state, only less than 1% of students qualify for that particular eligibility. So in California, we've got a series of conditions that we think are severe conditions. These are conditions that we're also going to be covering in tonight's lecture. So we've got deaf and hard of hearing, we've got visual impairments, we've got physical and health impairments, as well as medically and physically challenged. So these criteria in California, they're broad categories, but they capture these elements according to federal guidelines. Under federal guidelines, where they talk about deafness, deaf-blindness, hearing impairment, multiple disabilities, severe orthopedic impairment, TBI, as well as visual impairment. And visual impairment encompasses our blindness category. Who are the folks that tend to work with students with low incidence disabilities? Well, here they are. They include you or future you as school psychologists. It can be teachers, counselor, vocational rehab counselor, nurses, audiologists, signing assistants, braille assistants. It can be interpreters in terms of ASL, American Sign Language. It can be transcribers. It can be special education assistants, technicians, behavior support specialists, drivers, etc. So where do we have the funds in order to provide supports to students with low incidence disabilities? Given that students with low incidence disabilities, they tend to have a lot of needs, both physically, it can be cognitively as well as adaptively, behaviorally, etc. So the state actually provides us additional funding. Um, Students who have a low incidence disability, they have to be coded either as with a primary or a secondary, what's called federally handicapping condition. So the FHC stands for federally handicapped condition. Now, this funding can be used towards books, so Braille books for the blind, for instance, materials, equipment such as, say, a lift, such as an activity center, etc. We'll go over those things in just a bit too. Now, per pupil amount is multiplied by the number of students that are identified in each school district or SELPA to determine how much total funds you can allocate towards books, materials, and equipment. In terms of deaf and hard of hearing, let's go ahead and take a look at this video.
Guys, welcome back. Monday morning. Hope everybody had a great weekend.
For a child with hearing loss, no matter how good the technology is, they're listening through a damaged auditory system. We need to help them to hear what's happening in the classroom. If they don't hear the teacher, if they don't hear the questions and comments from other kids in the classroom, they're going to miss a significant amount of what happens, and that's not fair to them. We have to remember that classrooms are very noisy places. For a child to hear well in the classroom, we need to give them some special assistance. The first example we're going to show you today is to help you understand what a child with a hearing loss hears in the classroom with an FM system and what he would hear if we didn't turn the FM system on.
So let's get it going.
The teacher in this classroom has forgotten to put on his FM microphone. Without the microphone turned on, it's almost impossible for a child with a hearing loss to hear clearly. Let's listen to what a child with a hearing loss will hear with the FM unit turned off.
I know that we had written down at least 2 or 3 ideas each, and we had written them down in our notebooks. So if everybody remembered to bring their notebooks with them, you can reach in your...
Without an FM system on, the child is going to be hearing very muffled speech, or like they're listening from a very great distance.
We were talking about geography, and we had a...
Forgetting to turn on the FM system can happen to anybody, but don't count on the student to tell you if it's not working. Look for visual clues that he's confused, or watch the student trying to look around to see what's happening in the classroom. After a quick check, the teacher can turn on the microphone, check with the student, and make sure that all is working well.
Okay, good.
That gets the student back on track and gets the lesson going in the right direction.
You sounding okay now? Okay. So
once the FM system is turned on, the student is hearing as if the teacher was standing right next to his ear.
Generated a list of which jobs were important to know geography.
Making sure that the FM system works is the responsibility of both the teachers and the students. The students are responsible for advocating for themselves and should be encouraged to say something when the FM system either isn't working or is working poorly. As long as they can hear, they can compete. When there's only one microphone, we know the child will hear the teacher clearly, but they also need to hear the classroom discussion. If there's a pass mic, this microphone can be passed around from student to student, and then all of the students will have the opportunity to speak into the microphone, and the child with the hearing loss will hear everything they're saying. If there isn't a pass mic in the classroom, it's the teacher's responsibility to repeat what's said so that the child with the hearing loss knows what's happening. That means repeating the question if a child asks a question, or repeating what the kids say in their comments. Listen now to how other students' comments sound to a student with a hearing loss, and how disorienting it can be for a child when the teacher forgets to repeat the comments or the questions.
So who's got the next one? Who has another good idea? Aaron, what's your idea? Okay, it's funny, but that's a good one. Because you're going to be traveling a bunch of different places. You're going to have to know...
By continuing with the class and not repeating the other students' comments, the teacher quickly loses the attention of the child with a hearing loss. Let's hear again just how difficult it is for a child with a hearing loss to hear his classmates.
So let's talk about another one from someone's list on Friday that we had created. Who might have a good idea that we haven't talked about yet? Okay, Aaron, how about one from your list? Okay,
You see
that's
how
a good one.
important it is for the teacher to repeat the comments of other children in the classroom so that the child with a hearing loss can be a fully productive member of the class.
So Aaron just told us rock star. What do you think? Because as a rock star, you're going to be traveling to a bunch of
The
places.
two reenactments you just saw are two simple steps that can happen in every classroom to help children hear better. It's something that needs to be part of every educational day.
So take a moment just to envision that you are this particular student sitting in the classroom. You use the FM system, but your teacher somehow forgot to turn it on during class, or maybe during break, the teacher takes it along with her into the teacher's lounge, etc., right? So think of all these possibilities and what it's like to be that child. Okay. So let's talk about the various types of hearing loss. The first one we've got is what's called conductive hearing loss, which is where sound is not really getting to that inner ear. So you're hearing a lot of muffled noise. The next type of hearing loss is what's called sensory neural hearing loss. And this is where that inner ear, or there's a hearing nerve, an issue with the transmission. Somehow sound is not being fluidly translated through the various aspects of the hearing process. Something gets lost in there. You also have what's called mixed hearing loss. So it goes in degrees. You've got mild hearing loss, moderate hearing loss, as well as severe and profound. It escalatingly gets more and more challenging to hear. We also have what's called central auditory processing disorder. Essentially, these are issues related to listening. So maybe you have a hard time discerning different sounds. Like for instance, when somebody says the word cat, you might hear the word mat. About 92 to 96% of deaf children are born into hearing families. Did y'all know that? And approximately 2 to 3 of every 1,000 infants are born deaf or hard of hearing. Other facts, American Sign Language is the third most widely used language in the US. Did y'all know that? By the way, quick note, sign language is not universal. That means American Sign Language is going to look very different than, say, Italian Sign Language. And it's going to look very different than, say, English Sign Language, as well as Vietnamese Sign Language. Sign language is not universal. It's going to vary from country to country, just like a culture, right? You can't expect every culture to be the same or every language of a particular culture to be the same. Different gestures mean different things in different countries. All right. Did you all know that there's almost as many sign languages as there are spoken languages in the world? Because guess what? Deaf and hard of hearing folks exist in all countries, folks, and they have to develop a schema for communicating. So it evolves into the sign language. Things to consider when you're working with deaf and hard of hearing students. Now, a quick note, just because some children have what's called decent speech, people will automatically assume that they can hear. But it's been through a series of interventions and speech and language supports that this child who's deaf and hard of hearing may have adequate speech, but they still may have difficulties hearing. So the other thing to consider is location of sounds is difficult depending on the loss. So location of sounds, meaning is the sound from the outer exterior of the ear, or is it more located towards the inner side of the ear where it's making it difficult to actually hear? There's two levels of hearing loss. It's unilateral as well as bilateral. Unilateral is you can hear one side, but on the other side, other ear, you cannot hear. Whereas bilateral hearing loss means you cannot hear in both sides of your ears. Students who have hearing issues, they tend to have to fill in the blanks in conversations, and it can be very taxing in terms of just cognitive energy. Trying to make sense of all this external noise, making sense of what people say when it's muffled, it's exhausting. They can have a hard time understanding jokes because they may miss that punchline. Everybody laughs, but then they're the ones that are not laughing and they think that they're the brunt of the joke, that people are teasing them. Figurative language can be difficult for folks who are deaf and hard of hearing. They might hear the teacher, but they may not be able to hear students when students pose questions or when students respond. Students who are deaf or hard of hearing, they have what's called a lag time in interpreting and decoding sounds or phrases, statements, etc., and it makes it tricky for them to follow along in conversations. Again, don't assume understanding just because it goes back to that first point, they have decent speech, all right? In terms of school-based supports, there's various educational environmental supports that can be implemented. There's in-home supports, there's day classes, especially for auditory, oral, and American Sign Language classes. There's also inter-SELPA transfers, for instance, from one district to another district. Let's say your home district doesn't have a deaf and hard of hearing program, but your local school district, it's another school district, they might have a deaf and hard of hearing program. For instance, I know that, let's say in Riverside, there are programs there. There's a school specifically for the deaf and hard of hearing. So maybe a transfer, inter-district transfer to Riverside might be beneficial for the student. There's also various services, there's audiological services, there's clinics, interpreters and transcribers, ASL interpreting, real-time speech-to-text transcription. Sometimes in your even college, those of you who went to almost any college institution, you may have seen a peer who may have another adult figure with a particular box type tool sitting next to this particular peer, and the person is typing out the words of the lecture for this particular student. There's also in-classroom supports. There can be meetings, in-service trainings, professional development, extracurricular activities. There's also other services that can be deemed appropriate by the IEP team. Relating back to Ed Code, some important considerations in terms of developing an adequate and appropriate plan for students who are deaf. Firstly, we have to recognize the unique nature of deafness. Deafness does not equate to less cognitive abilities, alrighties? Just because you cannot hear, it in no way shapes or informs your cognitive abilities or your intelligence. Education in its own form of communication is respected and utilized, so there should be no diminishing of the use of American Sign Language, just like we wouldn't diminish a student for using Khmer or Spanish. We want to make sure that students have access to educators with specialized training. We want to make sure that teachers are proficient in modes of communication, such as, say, use of the FM systems. We want to make sure that parents are involved in this process. We want to make sure that our programs expose these kiddos to deaf mentors. Folks in the deaf community, guys, are big in terms of advocacy, are big in terms of disability rights and the disability movement. You want to make sure that the student has access to all educational components. So access to all various parts of schooling, such as sports, after-school dances, shows, etc. Vocational training and access as well, training them for a job. And of course, always educating them in the least restrictive environment, not making the assumption that because they're deaf, that all of a sudden that this equates to placement in a more restrictive setting. In terms of audiology, you will be working often with a audiologist if you're working with the deaf and hard of hearing student population. Here's the role of audiology. This role often stems from referring a student when they don't pass or cannot be tested at an initial triennial hearing screening. So let's say you are conducting an assessment for this kiddo, and your school nurse is just having a really hard time screening this kid's hearing. This is where you may have to call in your audiologist. Just know that with an audiology assessment, it tends to be only completed for students that are currently being evaluated for special education and related programs. Other considerations, you have a student that perhaps arrives at school, there's hearing aids, but there really is no record of any hearing loss. Again, you want to involve your audiologist at this time, consult with them. You want to make sure that you assess students for both hearing sensitivity and auditory processing disorders. Hearing sensitivity, all that means is how quick they are to ascertain sounds, to hear sounds. All right, how quick, the rate in which they respond to sounds. With auditory processing, guys, that's how we make sense of sounds. These are folks that can absolutely hear. Their hearing is just fine, but making sense of these sounds can be challenging. There's a difference, all right, between hearing sensitivity and auditory processing. If a kiddo has a hearing aid or a cochlear implant and you notice that they're having some difficulties, perhaps there's something going wrong with the cochlear implant, there's some tech difficulties with it, this is where you want to follow up with the student. You want to make sure if there is any supports in place already for the kiddo, and if not, make sure you have supports in place, either by following up with a 504 plan or pursuing the IEP route. The audiologist may be a part of developing what's called ear modes and loaning hearing aids as well. They are part of fitting and monitoring FM systems, as well as monitoring cochlear implants, and also giving portable sound field systems. And they consult often with our nurses. So if you are not friends with your nurse during your field work, please make sure to get to know them, get to know their roles, because if you've got a kiddo with some hearing difficulties, you may work with them, with the nurse as well as the audiologist. So particular assessments for deaf and hard of hearing students, you want to make sure that if you're using traditional standardized assessments, so I don't know, like the KBC, you want to make sure there's modifications, alrighties, such as using American Sign Language if needed. Just like you would for a Spanish-speaking student, you would have an interpreter. For deaf and hard of hearing students, you would use ASL as your interpreter. You could use portions of traditional standardized assessments as well so you're eliminating that verbal piece. You could use measures that are standardized on the deaf and hard of hearing population. So again, going back to those norms in the test manuals, looking to see if deaf and hard of hearing students were a part of their norms. So for instance, the DOS is normed on the deaf and hard of hearing community, the KBC, the Stanford Binet. You want to make sure that you provide assessments that have what's called minimal verbal loading. So that means you're not giving a lot of verbal instructions or directions, folks. Sometimes you may use a nonverbal measure, such as the unit, the C-tone, P-tone even. There's a complication with all of this. Yes, they may have deaf and hard of hearing issues, but did you all know that approximately half of the deaf and hard of hearing community also have additional disabilities? It can be perhaps other learning disabilities on top of the deaf and hard of hearing element. Some non-school psychology assessment instruments that is conducted with this population. By the way, Your speech pathologist may engage in some of this, your hearing specialist, your audiologist would engage in these types of tools. You would not be implementing these tools, alrighties, but it's something just to be familiar with. You've got the Ling 6 sound test, the SPELT, the receptive one-word vocabulary test, the expressive one-word vocabulary test, as well as any listening observations checklist. Again, the listening observations checklist goes back to that hearing sensitivity. How quickly can this child respond to sound? We've got some resources for you in terms of the deaf and hard of hearing community. Let's move into visual impairment. There's various types of visual impairment, one being low vision, the second being functionally blind, totally blind. There's also various classifications. We have what's called adventitious, which happens after somebody has normal vision, but then something happens to them and they become blind. We have what's called congenital blindness, which happens during the fetal development. So that means it's in utero. When, say, mom has baby in belly, it's prior to the development of visual memory. So let's take some time right now and we're going to look at what it's like to have a visual impairment.
Nei, da må du gå ut på gaten og til høyre.
Samme sender, hallo?
Siamson og co.
Kom inn, du.
Da er det inn til høyre, og så heisen opp til 5.
Hei, velkommen.
So take a moment and just process what it would feel like to navigate your world with that limited visual component. What you guys just saw in that video is what's called low vision. Alrighties, so there's some element that you can see, but peripherally beyond that, it's very tunnel vision. You can't really see beyond this tunnel. Alrighties. In terms of what the referral process looks like for those with visual impairments, we always do a vision screening, right? As part of any good comprehensive assessment, we make sure that we collaborate with our school nurse so that they can do that vision and hearing screening. We need to rule out that this kiddo's vision and hearing is just fine so that we can continue forward with our assessments, and our assessments are valid. With students who have visual impairments, however, there's going to be some sort of medical documentation revealing a level of vision loss in terms of this vision screening. Either a diagnosis of some type of blindness, perhaps there's some type of distance or near and distance acuity, those types of issues, some sort of documentation. There's also what's called a functional vision assessment, which looks at acuity, visual fields, reading level, light sensitivity, color vision, convergence, eye movement, muscle balance, binocular vision, depth perception, visual efficiency, all the things that our eyes do in terms of navigating our world. That's what a functional vision assessment does in terms of reading, in terms of walking from point A to point B, etc. We want to make sure that we evaluate the child's use of vision and their visual efficiency in daily activities, such as perhaps how do they access things in their environment, such as how they can sit from the chalkboard, or what kind of font they use in order to see, say some sort of reading materials on their little laptop. This assessment is done by a certified teacher of students with visual impairments. You are going to be conducting, say, that RIO part, records review, interviews, observations. The testing, however, tools or measures are going to be done by a specialist. It can be a certified teacher or a vision specialist. Parents, caregivers, and the child's teacher, of course, are always asked to give input about how the child is doing in regard to their community, as well as in the classroom. That's important information for us to know. We want to, in terms of the actual vision assessment, it helps to determine how this child is interpreting near and far information, what they can see in terms of their peripheral view, in terms of what their reading levels are, in terms of light sensitivity. I just said that earlier. I will move on. Also, we want to take a look at learning media assessment. So this is how the child learns best. So is it visual? Is it tactile? So they have to do something that's hands-on? Or is it auditory? We want to make sure we determine what their learning style is. We don't really necessarily want to teach them the one and only learning style. We want to embed those elements in everything that they do. So for instance, let's say this child is a tactile learner. Because of their visual impairment, they are very tactile. They like hands-on activities. We would want to consider embedding tactile elements into things that we teach the student. But there's going to be parts where we have to teach them coping skills. So say they have visual challenges, but they have to exist in a visual world. Therefore, we have to teach them certain coping. What do you do if, say, you're in a new space, you want to advocate for yourself, you want to ask somebody for help? If, say, you're in a new space and you don't know how to navigate this space. You also want to consider challenges that they may experience in mastering certain concepts. You want to consider their eye development. You want to consider direct intervention, such as adaptive intervention skills. You want to make sure that if there's any incidental learning that takes place, recognize that children with visual impairments, they're going to have a hard time with incidental learning. Incidental learning is just relates to how we learn by watching what others do. Because these children have visual impairments, They can't watch what other people do, folks. So that's going to be challenging. So therefore, there's going to be a lot of auditory information, talking out things, directing, etc. to teach. Overall, there's typical cognitive development. In terms of language, language is also typically developed as well. The hearing sense is actually very, very well developed with our visually impaired student. Again, there's a reliance on the tactile senses. Their motor skills can be delayed depending on opportunities. If you have a hard time navigating your world because you cannot see, it may create some barriers to you moving in this space. It also can create a hindrance in terms of exploring your environment. And of course, lastly, there's going to be some social emotional influence as well. If you are, say, a teen with visual impairments, and during the teenage years, you want to explore relationships, in terms of your sexual orientation is being developed. There's these times for exploration, but because you have a visual impairment, it can be challenging in that sense. So what would that do in terms of self-esteem, in terms of confidence, etc.? All important elements to think about. With school-based supports for students with visual impairments, there's early childhood programs, there's resource programs, again, there's inter-SELPA transfers, there's also schools for the blind. Specifically in Fremont here, there's a school designated for the blind. There's also teachers that are certified and trained for the visually impaired. There's Braille transcribers, there's special education Braille assistants, there's also orientation and mobility specialists that we may also work with. With accommodations, we want to make sure that we think about educational implications of vision loss. What would that mean? Putting yourself in the shoes of somebody who experienced vision loss. What would you need in order to be successful at school? You want to make sure that there's an awareness of the level of visual functioning. Again, there's mild, moderate, profound. What levels is this person's vision loss? We want to make sure we determine how the student works and learns and how to best support them. We want to make sure that there's accommodations in place for the kiddo in terms of seating, lighting, cues, Braille. We need to use like a visual schedule, but instead of making it visual or images, we're using Braille. Using assistive technology, so Braille translation software, a screen reader, a magnifier, talking calculators, all those would be possible accommodations. Assessments for those with visual impairments, you want to make sure that your measures, again, are normed or standardized on the blind and visually impaired population. Again, looking back at those test manuals, seeing if the test was normed on the blind and visually impaired. You can give traditionally standardized assessments, but you have to modify it, because what is the point of you showing a series of blocks and asking this person to replicate it, but they can't see? That would be pointless, right? You want to make sure there's modifications. When you are modifying standardized assessments, guys, for any types of eligibility, if you're modifying a standardized assessment, you no longer can use the scores for it. It is solely informal data used as observational points. Alrighties, you cannot use the scores. That would be invalid use of the measure, because you're changing it through these modifications for the students because of their need. You can provide portions of traditionally standardized assessments, perhaps eliminating some of that visual spatial subtests if you need to. Other considerations for visually impaired students, you want to examine when this vision impairment began. When did it start? You want to look at, again, the degree of visual functioning and look at etiology. We have some resources as well for you. So if you want to delve deeper, you absolutely can. In terms of medically and physically challenged student population. These are our students who have very significant cognitive, medical, and physical difficulties, guys. They may have multiple disabilities, but these are our students who, according to the CASP, they are performing at the level 1 because of this significantly below average general intellectual functioning. It also happens and exists with deficits in adaptive behaviors, those self-help skills. They may be reliant on others for activities such as daily living tasks like feeding, toileting, etc. They have medical needs that are chronic in nature, so it's not a one and done deal. These are chronic conditions that have existed for a long time. They may require immediate medical responses. Perhaps they may need a full-time on-site nurse. They may need a special education health tech or somebody who's specially trained in terms of the instructional staff, in terms of the behavioral approaches, in terms of working with students, say, who are medically fragile. They have to be specifically trained. In terms of school-based supports, this is what it would look like for students who have medically or physically disabling conditions. You may work with teams that are specialized in administering oxygen. They may specialize in providing oral and nasal suctioning. They may be trained in administering medication. They monitor seizures. They administer diastat after a seizure happens. They administer and prep G-tube feedings, safe lifting. They may use adaptive equipment. When you work at a school that is for children who are medically and physically disabled, there's going to be an environment in it that involves a multisensory element. There's going to be perhaps, say, a room that's designed to block out noise. There's a place to control temperature and lighting. It's meant to stimulate senses of auditory, visual, smells, olfactory, tactile, and the vestibular systems. It's created and set in a way that helps to change certain behaviors, increase or promote focus, as well as a sense of well-being and self-esteem. It's supposed to be a relaxing environment. Sometimes I've seen some school districts use this as a nap room. It should not be used as a nap room. It's supposed to be support. And napping is not an outcome of a student being supported in terms of accessing curriculum, right? Or on the other end, it was used as, say, a room to confine a student. Also, that's inappropriate. Staff should be actively working with students on IEP goals within this multisensory environment. In these environments, you're going to have sensory rooms that have certain lighting, and at the same time, this lighting isn't like lighting you would see at a rave or something. It's lighting that's supposed to be very mild so that it doesn't provoke any seizures. By the way, those of you who may end up working at a site that is designed for students with, say, moderate to severe disabilities, you're going to work with these specialized health techs, these specialized special education teams, as well as your nurse. You're going to have an on-site nurse. At these moderate to severe placements, you're going to see a lot of these elements that we're talking about. In terms of assessment, guys, you're going to engage in what's called a functional scheme assessment. So this is only used for students who have significant multiple disabilities, guys. And because of these significant disabilities, we hypothesize their functioning is about below 48 months developmentally. There's a checklist involved. It looks at 20 areas of typical childhood development. And then the results inform teachers and service providers in terms of what do we need to do in our material selection and how do we teach students in a way that best meets their needs. It can be completed as a team and it includes parents. You may use various equipments. You may use, let me pull up my laser. You may use what's called a stander, as this little girl is seen in. You may use an activity chair, as this little boy is shown in. You may use a kid walk. You may use a lift. All these elements to be able to assess the kiddo. With orthopedic impairment. So Ed Code defines orthopedic impairment as an impairment that is caused by congenital anomaly, which can be caused by disease or other causes. All right. Orthopedic goes back to movement, leg movement, pedic, feet. All righties. With students who have orthopedic impairments, we want to make sure that we are evaluating them using those tools that I just mentioned earlier. So let's go back. For instance, the equipments, the standards, if we need to, the activity chair, kid walk, etc. We want to make sure that we identify students with orthopedic impairment before they enter school. Sometimes they're missed in terms of our screeners. And it's often because with orthopedic impairments, they don't show up until a later age. But your teacher may start to notice that, hey, this child has poor coordination. They have a lot of accidents. They complain often of pain. The assessment must include a thorough medical evaluation, alrighty, guys, by a licensed physician. Other data can include observations as well as assessments of how the orthopedic impairment affects the child's ability to learn at school, as well as observations looking at their mobility, how they navigate different spaces. It's also important to consider their social and physical adaptive behaviors. So you're going to use things like checklists, rating scales, interviews. Again, just to measure the severity of any limitations that they may have in terms of their movement and mobility. Some orthopedic impairments include bone diseases, cerebral palsy. By the way, guys, I have seen it in the past where somebody listed cerebral palsy as other health impairment. There was this child that had cerebral palsy and the team went with orthopedic impairment. It makes no sense, all right, folks? If you've got a child with cerebral palsy, automatically you should think of orthopedic impairment as the eligibility, all righties? There's also muscular dystrophy, there's scoliosis, spinal cord injury, there's brachial plexus, which is also known as Erb's palsy, there's hydrocephalus, there's spina bifida, spinal muscular atrophies, various orthopedic impairments. Here are some OI resources for you all. All right, let's go ahead and dive into traumatic brain injury. Let's take a look at this kiddo.
Hi, I'm Christian and I'm 10 years old. Last year I had an accident and I hurt my brain.
Thank you.
You're welcome. You're welcome. You're welcome. I was out of school for a long time. I'm doing a lot better now and I'm even back at school. I'm glad to be back. I missed my friends, but when I came back, things were different. It was harder to concentrate and get my work done. I got frustrated a lot. My mom and my teachers asked Barb to help me. She's an SEA, a special education assistant. That means she's there to help me in class. I wasn't sure about Barb when she started. I didn't want the help. I was worried it would look weird and everybody would make fun of me. But it hasn't been like that. It's been great. Barb is my SEA. She helps me a lot. She helps me stay organized, practice reading, we do math games together, and she helps me get ready for tests. Barb knows that sometimes I need some space, so she helps me find a quiet place to walk or even take a break when I need it. I'm doing better at school and I'm glad I have Barb.
Alrighties. Okay, let's also take a look in terms of the medical side of traumatic brain injury.
This chapter will help you understand brain injury and more about your loved one's diagnosis of traumatic brain injury, sometimes called TBI for short. Traumatic brain injuries are those caused by a blow to the head or from violent movement of the head.
That could be from striking the head against a car windshield. It could be related to a fall and striking the head. It could be related to military explosion or shrapnel penetrating the skull.
A person does not have to have an open head wound, a skull fracture, or even a loss of consciousness to sustain a traumatic brain injury.
No two people are alike, and no two brain injuries are alike. Doctors classify traumatic brain injuries as mild, moderate, or severe, depending on the initial length of loss of consciousness and post-traumatic memory loss. There are overlaps in the symptoms of each of these classifications. The terms mild, moderate, and severe may not correlate or describe the expected outcomes in a person's life.
A mild traumatic brain injury occurs when the patient initially loses consciousness for 15 minutes or less, if they have any memory loss about the trauma event, or they feel dazed, disoriented, or confused. It's often called a concussion. The majority of traumatic brain injuries are initially rated as mild. Moderate traumatic brain injuries include a loss of consciousness from 15 minutes to a few hours, followed by a few days or weeks of confusion. Severe traumatic brain injuries affect less than 10% of patients and involve a loss of consciousness for 6 hours or longer after injury, or after a period of clarity. People who remain unconscious for a very long time may be in a coma or a vegetative or minimally conscious state.
Physical symptoms of traumatic brain injury can include difficulty coordinating balance and walking, blurred vision, headaches, trouble speaking and swallowing, and lack of bowel and bladder control. People with traumatic brain injury may have trouble moving their body normally. Doctors call this motor impairment. The person may have seizures, vision problems, and changes in sensory perceptions, sleep patterns, and sexual function. Persons with traumatic brain injury can have personality changes, trouble communicating, and memory impairments. They may also be depressed and disoriented, have mood swings, be forgetful, and have difficulty forming sentences or choosing vocabulary. They may act inappropriately and struggle with reason, focus, and logic. After a brain injury, conversation with your loved one may be difficult. He or she may have poor concentration, a limited attention span, or difficulty remembering what was said. As the loved one of a patient with traumatic brain injury, it's a good idea to prepare to adapt to these changes by developing coping skills and finding resources for support.
It's helpful for the medical team to understand what your loved one was like before that injury, so they can get a sense of their general intellect, their general rapport with people, the things they like to do. All of these little things can be used during rehabilitation to try to help reestablish that quality of life that your loved one once had.
The first step toward helping your loved one regain any recovery possible is to assess his or her condition using one or several diagnostic measurement scales.
Right after a brain injury, a medical team may use the Glasgow Coma Scale to measure the injured person's level of alertness. The Glasgow Coma Scale ranges from 3 to 15. The highest score of 15 describes a fully awake person, while the lowest score of 3 describes a person who is in a deep coma. This scale measures 3 things: eye response, verbal response, and motor response. A coma score of 13 or higher indicates a mild brain injury. 9 to 12 indicates a moderate injury, An 8 or less indicates a severe brain injury. The Rancho Los Amigos scale.
Alrighty, folks, so that was just to give you a glimpse into the medical realm. Alrighties, we're not medical practitioners, folks. We are school psychologists. So I want to bring you all back to the definition of TBI according to our federal guidelines. So, like the video said earlier, TBI is an injury caused or an injury to the brain caused by some sort of external force. Something happened to the person, alrighties, resulting in that partial functional disability or even psychosocial impairment. At the schools, again, there has to be that adverse educational impact. Now, something to keep in mind here is that this term TBI applies to open or closed head injuries, alrighties. So, areas that could be impaired could be cognition, language, memory, attention, reasoning, abstract thinking, problem solving, sensory perceptual abilities, motor abilities, physical functions, information processing, speech. TBI, guys, does not apply to injuries that are congenital or degenerative or brain injuries induced by birth. Alrighties, it's something that happened to you while you have existed in life. In terms of assessment at the schools, this is what we're doing when we assess for TBI. We need to be able to identify various cognitive strengths and weaknesses. So you may be using measures that can gather you processing speed information. You want to use measures that can gather attention information. You want to use tools that can measure memory. Look at tools that can allow you to repeat various information to see what is the best modality that the child learns in. All this is saying is that how often do you need to repeat something in order for this child to learn it? So let's say if you're teaching this child to play a card game, how many times do you have to teach it and repeat the task for this child to be able to do it independently? You also want to provide assessments that look at problem solving, that look at the child's cognitive flexibility, planning, prioritizing, and how they organize or strategize. Some other tests specifically to consider when you're assessing kiddos who are suspected of TBI. We've got the MMPI, the Beck's Depression Inventory, the Temperament Analysis, the Wilcox-Johnson Psychoeducational Battery, the Booklet Category Test, the Wisconsin Car Test, the RAT, the MVPT, the TVPS. All these are particular measures that can be used if they're available at your particular school district. We also have a variety of TBI resources. Some more broader professional organizational resources, as well as other website resources. Now let's talk about general types of accommodations for students who have a low incidence disability. What's low incidence again? What's the rate? Less than 1%, okay, folks? Less than 1%. Alrighty, so some general things to keep in mind are 4 various types, alright? So you've got your presentation, you've got your response, setting, and timing/scheduling. Presentation is how we provide the information. Do we repeat directions? Do we read the directions out loud? How are we providing the information? Response type is talking about how the child may give their answers. How do they engage with us to let us know that they are capable of answering our question? Do they mark their answers in a book, or do they point gesturally to answers? Setting type is also considering, do we have them in a study corral, a separate room? Is there special lighting used? What's the setting like? Can we alter the setting or the situation in which we are assessing them? In terms of timing / scheduling, we are thinking about, do we give more time, less time, reduced time, breaks, etc., to be able to retrieve the child's best performance? Do we do things in multiple days? Do we break things up? What is it that we're doing in terms of our timing and breaking up of these subtests or lessons or teachings? What are we doing with that time? All right, folks. So with that, okay, so now it's time to go to the discussion board, and I'll go ahead and give you specific directions on what you're going to do.